your topics is mainly menopause, but then after that also postmenopausal bleeding. Okay. Now let us first come to the subject proper. Before introduction of the subject, I will tell you about a few things that you must read before appearing in the final examination. Now, you are supposed as undergraduates to at least know the basic things. Now, what do you mean by basic things? One particular aspect of the basic thing is in every branch of medicine, be it medicine, surgery, or gynae, you will see there are certain terminologies coming up. And the terminology, you will be asked as an undergraduate, define these, define that, something like that. I'm giving you an example, then it will be more clear to you. For example, if you are asked, define normal labor, or in other words, what do you mean by normal labor? Now, whenever you try to define something, now in one sentence, sometimes it is not possible to properly define. In that case, you have the option to break it up. For example, if you are asked what is normal labor or define normal labor, then you have to say there are several parameters to be fulfilled to call it a normal labor. Like, number one, expulsion per via naturalis. That means expulsion per vagina. So that is condition number one. Number two, of a mature living fetus. That means the fetus must be mature. Mature means how much? 37 completed weeks. So mature living. A dead baby delivered vaginally doesn't constitute normal labor. So mature living fetus. Then again comes the next question, the presentation. The presentation must be vertex. So if a baby is delivered vaginally very smoothly, but the presentation is not vertex, say for example breech, then again it is not a normal labor. Followed by that of the afterbirth. There is another condition. That means labor is completed very smoothly, baby is delivered, you cut the umbilical cord, separate the baby. But the next moment comes, that is followed by the delivery of the afterbirth. Afterbirth we mean that is also called placenta. Another name of placenta is called afterbirth. So followed by that of the afterbirth. That means only the delivery of the fetus smoothly, normally, doesn't constitute normal labor. So the placenta should also be expelled without any delay. And last point, the whole process, that is normal labor, whole process should be spontaneous, uncomplicated and not delayed. Spontaneous. What does it mean? That means sometimes we induce the labor. We give certain injections, for example, oxytocin injection or prostaglandin pessaries vaginally to start the labor. And this process of using drugs to start the process of labor is called induction of labor. So, if you induce a labor and then everything is alright, still it is not considered as a normal labor, because by definition, normal labor should be spontaneous. So, spontaneous, uncomplicated and not delayed. Not delayed, that means, say, patient is in labor for 24 hours or more, like that. It is not to be considered a normal labor, because there is a time limit also. So that's, I have given the example of this definition because most of the cases in your undergraduate examination, in the oral practical especially, you will be asked a lot of questions which are basically definitions. Now let us come to the subject matter proper, that is menopause. Now what is menopause? Menopause means menstruation and pause means, as you all know, stoppage. So basically, in a plain language, menopause means stoppage of menstruation, isn't it? But simply saying stoppage of menstruation will not be occur in this case. That means actually when there is stoppage of menstruation along with cessation of the ovarian activity, then we call it menopause. And actually, if you consider the reproductive life or reproductive life period of the woman, it is actually the end of the reproductive life process. That means at puberty, there are certain changes that comes in the case of the female girl, and that is the maturation of the follicles, the ripening of the follicles, and then every month one ovum is ejected, that is called ovulation, and many are actually atretic. Commonly, it is believed that against one particular ovum, that means one follicle, ovulating and releasing the ovum, there are almost 1,000 follicles that do not progress to the stage of maturation, rather they regress. So one ovulation and one follicle and 1,000 follicles in very small stages of development, they become atretic. In that way, the stock of the ovum in the ovary gets gradually depleted. And in this way, time comes when there is no further follicles present and no ovum present in the ovary. So ovulation stops. Also, there is stoppage of menstruation. Now, another thing, the diagnosis of menopause. The diagnosis of menopause practically is a little bit retrospective. Retrospective means suppose a woman has stopped menstruation in this cycle. Previous cycle she had a menstruation period. This cycle there is no menstruation period. Menstruation occurring. Can you call it a menopause? No. Then how do you diagnose it? So we have again in the definition, there are certain terms which are used in the definition to make it clear cut. And what is that? It must be for a period of 12 months or more. Better to say at least 12 months to call it a menopause. Why? Because sometimes it is seen the stoppage of menstruation or stoppage of cessation of bleeding per vagina, as usually occurs in the reproductive age group. It can be in different ways. In some women, there is sudden stoppage. So last month she had menstruated, this month no such, next month no such, like that. So this is one way. Another way, it is a different sort of stoppage. Say she has got a 28 or 30-day cycle. It becomes 30 to 45 days. Then the next cycle after 2 months is 60 days. Then after 2 months it is 90 days. And in that way the gap between the two period increases, and certainly one time she notices that there is no menstruation for a successive number of cycles. That way it can stop. In any case, whatever may be the way of stopping, usually this menstruation stops, and the age of menopause, that depends on several factors, particularly for example, the Indian women population, they're much earlier, say around 46 to 47 years on average, whereas the European or the American, it's a little bit longer, say around 50 years, like that. So that is all about the diagnosis of menopause. Now, regarding the timing, nowadays, most of the competitive exams will have to sit for, they're all multiple choice questions. Now, you should start making the stock of multiple choice questions from your undergraduate days. Because if you complete your undergraduate curriculum, then you appear in competitive exam. It is not possible unless you have a already basic stock group of questions already prepared. So that's why it is my way of teaching. I always encourage you to at least have some of the basic things on which this MCQ question appears. So in our country, if the average age is quoted around 46.5 or 40, maximum 47 years, that's all right. And the European and Americans, there it will be around 51 years or 50 years, like that. Now, actually, then what happens during menopause? The stoppage of menstruation is the outside manifestation of the biological activities occurring inside the body of the woman. And what is the biological activity occurring inside the body of a woman around menopause? Now, I expect that all of you have passed physiology, so I will also expect that you know the basic physiological facts that occurs during the reproductive period, and also the changes that occurs beyond menopause. What is that? Now, from the time of puberty, what happens? Yes, first you'll have to remember that hormonal changes occur during the entire period of the reproductive life of a woman. Now, unlike the males, their hormonal activities in female is a little bit different. What sort of difference is that? Yes? বলো, বলতে কোনো অসুবিধা নেই, ভুল বললেও কোনো অসুবিধা নেই. So the basic difference is, in case of females, there is fluctuation of the hormones, whereas in case of males, there is no such fluctuation. That's why in majority of textbooks of endocrinology you will find that in case of females, the hypothalamic centers are called clonic centers. Clonic means ups and downs. So there is a rise of FSH going to a peak, and then again it falls. Rise of LH, and there is a peak, and then again it falls. Similarly, there is the steroid hormones, estrogen and progesterone, there is rise and fall. But if you analyze the hormonal activities of a male person, there will be no such. Average, say, diurnal variation is there. It cannot be like a straight line, some sort of variation of, so today you make the sampling of LH and tomorrow or day after tomorrow it will not be the same. But basically there is no such obvious fluctuation of hormones. That's why this male hypothalamic centers are called tonic centers, whereas the female hypothalamic centers, they are called clonic centers. You get my point? So that is the basic thing occurring here. Now another thing, this is the hormonal changes. Another thing, if you go histopathologically or histologically, you will find a lot of activities occurring inside the ovary. What activity is going on inside the ovary? The follicles, yes, very good. The follicle starts maturing. Now the follicle starts maturing, but the funny thing is, of all the follicles that are preparing to get matured, only one will be to the fullest maturity, and the rest becomes atretic. I've already said against one follicle, at least 1,000 becomes atretic and they are lost from the body. So if 1,000 is lost, now I am coming to a little bit of mathematics just to make it clear for you to remember in your mind. So if 1,000 follicles are lost due to atresia, then the whole reproductive age group, so for example, if you consider the reproductive age group starting from say 15 to say 45 or 50 years. So 50 to 50, how much? 35. So 35 years. Now multiply each year by 12 months, then 35 into 12. So that much number of follicles actually matures. But then again, you multiply by 1,000, because I have already said one follicle maturation, 1,000 becomes atretic. Now you just calculate and tell me what the figure comes to it. Yes? 4 lakh. Very good. Okay, sit down. So you understand 4 lakh. And do you know how many follicles they are at birth? Very good. This is also an MCQ question. So 2 million. With 2 million you start, and 2 million means 20 lakhs. Now of these, another already in the reproductive age group is lost, and the rest of they do not mature at all. Why they don't mature at all? Because the changes of the hormones, they do not stimulate these follicles further beyond the age of menopause. Now, actually, nowadays the hormone action, you all know, they are explained by receptor status. For example, if you give a hormone, say estrogen to a woman, the biological action of this estrogen hormone will only occur if there are good number of receptors in the ovary. So you give estrogen, it acts on the ovary, it acts on the endometrium, it acts on the vagina, all. So, but all depends on the number of receptors. If you have got a small number of receptors, the biological action of the hormone will be much less. Whereas, if you have large number of receptors, the biological action will be immense. So, it all are now explained on the basis of the number of receptors present, like that. Now, in case of menopause, what happens? Gradually, the ovaries do not respond to the hypothalamic hormones. They become a little bit refractory, and ultimately the feedback between the hypothalamus and the ovaries are lost. With the result, what will happen if the response is lost? Very good. So FSH and LH, the gonadotrophic hormones, they suddenly start rising. They start rising because estrogen and progesterone gets lower and lower. So to maximize the effect of this FSH and LH, the body produces more and more FSH, more and more LH, but it becomes refractory. So actually, menopause is the culmination of ovarian failure. This is normal, ovarian failure. But sometimes it is abnormal. When? Yes? Yes? Abnormal in the sense, sometimes you will find that the menopause appears much earlier. We call them premature menopause. Premature menopause. So a woman having her menopause starting at the age of say 44, 5, 6, it's alright, agreed. But if a woman has got menopause at the age of say 36, 38 years, will you accept it as normal menopause? So we'll call them premature. Actually, By definition of the textbook, it is not 38 or 39 years. It is defined, you will find in the textbook, where the basic definition there is premature ovarian failure or premature menopause when it occurs by the age of 35 years. So that is the actual cutoff. Now, another thing coming out, another terminology that is called perimenopause. What is perimenopause? Peri means what? Around, circulating around like that. So, perimenopause means the time period just before menopause, at the time of menopause, and just after the menopause. This whole span, we call it perimenopause. And at this period, another term is also used to denote the perimenopause. What we call it, climacteric. Climacteric, that is also important. Now, this menopausal transition, actually, there are two things to remember. One is there is change of hormones inside the body occurring at the time of menopause. Number two, the effects of changes of the hormones inside the body. So if you know this basic thing, you don't have to cram. You will just think about all the biological action of all these hormones and you can answer questions properly. For example, what happens at the time of menopause? Already we have said the follicles are now no longer much active follicles are there. And if there is not much of active follicles, naturally what will happen? The production of progesterone and estrogen will be much lower. On the other hand, to stimulate the follicles, the hypothalamus will go on secreting the gonadal hormones, FSH and LH, higher and higher and higher like that. And what will happen to the body? The body also will undergo certain change at menopause or after menopause. Yes? That is the symptom that we are getting. But what the body will reflect as the changes the hormones occur inside the body, what will be the findings in the body? That means whenever a hormone acts, there is an end organ of tissues on which the hormone acts. That is one, very good. Anything more? Now you see the hormones estrogen and progesterone, they act on the genital tract. You all know that. Estrogen and progesterone acting on, say, endometrium, it acts on the fallopian tube, it acts on the cervix, and also it acts on the vagina. You all know that. But again, they also act at other levels. That is, we call it urogenital tract. We have told you about the genital tract. Now the urinary epithelium, which is also called urothelium, that is also affected by estrogen. That's why what happens, when estrogen level falls down, the endometrium becomes atrophic, the vaginal cells also become atrophic, and the trigone of the bladder and urethra, they are also to some extent atrophic. What the result will be? In case of vagina, it will be atrophic vaginitis. Agreed? Atrophic vaginitis. Similarly, there will be, whenever there is atrophic vaginitis associated with that, there will be some difficulty in intercourse because of this atrophy, and there will be also, very good, dyspareunia. What is the definition of dyspareunia? Yes. Dyspareunia by definition is when obvious pain is felt by the woman concerned during the act of sexual activity, and or coitus or intercourse. We call it dyspareunia. There are many causes. It's a different, altogether chapter. Very important chapter, of course. So, the changes of the hormones will ultimately lead to the changes in the anatomical level also. In the vagina, in the endometrium, over the cervix, even on vulva as well. So these all will show atrophic changes, and the urothelium being affected, so there will be atrophic trigonitis and cystitis and cystiurethritis, which will be more common in this age group. Okay, now you all were talking about hot flashes. Now, before that, I just want to highlight a few hormonal changes. You know, all this still to recapitulate and emphasize the different levels of hormones. We have already said the serum FSH rising. Serum E2 in the earlier stages of menopause, very early stage of menopause, either it remains normal or there may be slight elevation. But certain other hormones that are reduced, AMH, you know, anti-Mullerian hormone or AMH, inhibin is also reduced. Inhibin is actually follicle releasing FRIS, another name is FRIS. Follicle receptor inhibiting substance or FRIS, that is also reduced, and antral follicular cell count, that is also reduced. And during menopausal transition, again, inhibin is reduced, FSH raised, E2, that is estradiol, variable or normal, AMH reduced, and antral follicle count is also reduced. And when it comes to the exact postmenopausal period, the changes will be E2 definitely reduced, FSH and LH both increased, and also you should remember another thing, hormonally this is very important for your exam purpose, particularly MCQ also. What is the biological hormone, the type of estrogen in the reproductive age group most prominent? What is it? No, it's not E1. Question is, what particular estrogen is prevalent in the active reproductive stage of a woman? Very good, estradiol. More specific, estradiol 17 beta it is also called. So estradiol is a predominant estrogen in the active reproductive phase, whereas in the menopausal phase or postmenopause, the predominant estrogen available in the body is basically estrone. There are three types of estrogens, isn't it? E1, E2, E3. E1 is estrone, E2 is estradiol, E3 is estriol. There is a fourth one also, estetrol, but that is only available in the fetal body in a very transient manner. So basically we deal with E1, E2 and E3. E3 is the weakest, E3 is the weakest, estradiol is the weakest, E2 is the strongest and E1 in between. So main estrogen component in the woman in the reproductive age group is estradiol, whereas peri and postmenopause, the main estrogen present in the body is estrone, E1. Now let us come to the clinics, that is menopausal symptoms. So you were saying the menopausal symptoms, please, how many points you can have? বলো বসে বসেই বলো না একটা তো বলেছিলে hot flash আর yes. Well, it's a long-term complication. It's not immediately seen. Anyway, I do accept. It is another. Then, any more? Now, hot flashes doesn't come alone. There are so many annoying things occurring along with the hot flashes. There is night sweats, sleep problems and sleep disturbances, and along with these hot flashes and light sweat and sleep problems, there is already we have told it, that is vaginal dryness with urogenital symptoms. Vaginal dryness with urogenital symptoms. And two more problems or symptoms we also come across. These are mainly psychological, that is mood changes and depression. Mood changes and depression, and also the sexual function is affected because of definite decrease in the libido. So these are the most common symptoms that we come across in case of the menopausal woman. So to establish a case of menopause, as a clinician, you ask all these symptoms to the patient and you try to find out whether these are present or not. Along with that, the cessation of a menstruation regularly occurring in the last 6 months and probably last 1 year, that is 12 months, then clinches the diagnosis of exact menopause. Now, question arises, would you go for hormonal assessment to diagnose the case of menopause? Yes or no? Normally not done, but yes, there are conditions where you should. Where? Normally করা হয় না, কিন্তু কিছু কিছু ক্ষেত্রে it is indicated. Yes? Very good. So if it is premature, then it is better to have an authentication of this problem. After 33-4 years, a woman has come to you and saying that she is having skipped menstruation for 6 months, 7 months. So primarily what should you do? তোমার কাছে 6 months, 7 months of pregnancy, menstruation stopped হয়ে আসে, প্রথমে আমরা কি করি? You do a prick color test, pregnancy test একটা করি to rule out any pregnancy. No pregnancy. Then what you should do? আরে prick color তো নেগেটিভ, তাহলে একটোপিকটা প্রেক কালার নেগেটিভ, তো কেউ তো প্রেক কালার পজিটিভ হবে। এনিওয়ে, সেটা যদি তোমার মাথায় থাকে তাহলে তুমি বড়জোর ইউ ক্যান গো ফর অ্যান ইউএসজি, বিকজ দ্য ইউএসজি হ্যাজ দ্য অ্যাডভান্টেজ, যেমন আমরা প্রেগনেন্সি ডিটেক্ট করি বাই প্রেক কালার টেস্ট, ইট ইজ অ্যান ইনডাইরেক্ট ডায়াগনোসিস অফ প্রেগনেন্সি। দ্যাটস ওয়াই দিস HCG positive diagnosis of pregnancy, it is also called, you will be seen in some textbooks it's written, called chemical pregnancy. That means pregnancy which has been diagnosed by chemical means, that is HCG status, that is called chemical pregnancy. Next, if you do the USG, the advantage is if there is an early gestational sac, you can locate the sac, and it's a very diagnostic important finding, particularly to rule out ectopic. তাহলে ectopic আমরা কি করে রুল আউট করব? আমি একটা পেশেন্টের দেখলাম তার প্রেক কালার পজিটিভ, মিস পিরিয়ড হিস্ট্রি আছে, প্রেক কালার পজিটিভ, তাহলে এসসিজি পজিটিভ মানে কেমিক্যাল প্রেগনেন্সি তার আছে। Now if I do an USG and I find that the uterine cavity is empty, that means ectopic. তার মানে আমার এসসিজি বেরিয়ে আসছে বডিতে, অথচ আমি প্রেগনেন্সি স্যাক পাচ্ছি না, তার মানে ইউট্রাসের মধ্যে প্রেগনেন্সি স্যাক নেই, দ্যাট মিনস ইট ইজ হাউসড এলসওয়্যার। সো দ্যাট ওয়ে ইউ ডায়াগনোজ একটপিক প্রেগনেন্সি। তাহলে একটা তো হলো যে প্রিম্যাচিওর ওভেরিয়ান ফেলিয়ার যদি হয় বা প্রিম্যাচিওর মেনোপজ হয়, দ্যাট ইজ আ ভ্যালিড ইন্ডিকেশন ফর ডুইং অ্যান FSH LH। কারণ তুমি খালি আদার সিমটমস দেখে তাকে তো কনফার্ম করতে পারবে না, যে তাকে যদি বলে দাও যে you have got a premature menopause only from symptoms, she may bounce back, তাই না? So you should always have your backup ready. So you advise her to do the FSH LH test and repeat it after 1 month, etc. And if you find the consistent finding of FSH and LH increased, Then you can diagnose, and along with symptoms, symptomatology should also be there. Symptoms will be hot flashes, sweats, headaches, sleep disturbances, and mood changes and psychological depression, and sometimes the lady becomes irritative. So these are the other findings that may be associated with it, and definitely in some cases also there is a decreased libido, and all these things along with the other features of decreased hormones like atrophic vaginitis and atrophic trigonitis and senile vaginitis. Incidentally, let's say a little bit about atrophic vaginitis and senile vaginitis. What actually is the symptom of atrophic and senile vaginitis? One is already you have seen dyspareunia. Pain during intercourse, dyspareunia, dryness, also dryness of the vagina, sometimes a little bit itching sensation there. So all these together constitute what is called atrophic vaginitis. What should be the treatment in such cases? Yes. What sort of hormone replacement? Oral. Yes. SCRM, well, SCRM is not a very good choice in such cases. Actually, atrophy has occurred because the trophic effects of the hormone estrogen is not there. So we'll have to supplement that. So there are two ways which way you can supplement. Yes, better and safer is local estrogen therapy, estrogen ointments, estradiol, trade name is Evalon maleta ointment পাওয়া যায়, Evalon, that you can use. Or nowadays another is coming into the picture, that is conjugated equine estrogen. Trade name is Premarin ointment you can apply. Sometimes this tablet is not available, then what our teachers used to give is a novel way. They used to use linodol tablet. So you crush the linodol tablet, mix it with some bland ointment, and then apply. Because it gives a very remarkable change in the symptomatology. So it can be used, but it should always be used in a very short time period. Now, regarding serum estrone, we were all talking about serum estrone, particularly in the postmenopausal age group. Now, how this serum estrone is produced? Now, if you go to the production of the hormones, the sex steroid hormones in the body, you know there are how many sources of the steroid hormones in the body? Very good. So there are two sources. One is the ovary, which is the predominant during the reproductive age group, and the other is the adrenal. Adrenal also produces sex steroids. Actually, adrenal produces three group of hormones, most important: glucocorticoid, mineralocorticoid, and sex steroid. So adrenal produces both the sex steroids, and the ovary also produces the sex steroids, but the pattern is a little bit different. What is the basic type of, this is also an MCQ question often asked, basic type of androgen produced by the adrenal? No. Testosterone basically liberated by the gonads. In case of males, mainly the testis. In case of females, also it can be produced by some small amount from the ovary. Yes? Androgen, but what type of androgen? Yes, DHEA-S, DHEA or DHEA-S. So almost 90% of the adrenal androgen is DHEA-S, dehydroepiandrosterone and dehydroepiandrosterone sulfate. That's the marker of adrenal androgen. And In case of the ovary or the gonads, the testes, they mainly produce testosterone. Okay. So by looking at the type of androgen, we can say whether it's a gonadal androgen or adrenal androgen. Now then, how this estrone comes? There is another androgen which is also equally important in the body, that is called ADD, androstenedione. ADD, androstenedione. Now this androstenedione, it can come from the ovary. It's a common hormone. Androstenedione is a common hormone in the sense that it's produced by the ovary as well as it's produced by the adrenal. Now this ADD circulates the body, and this ADD is converted into estrone and testosterone in the fat mainly. So particularly fatty women after menopause, there is a rapid conversion of ADD to estrone. Okay, that's why obese women, they have got more estrone compared to estradiol in the postmenopausal age group. So that is the source of androstenedione. That is the source of estrone in menopause. Now let us come to the long-term effects of estrogen deficiency. এবার বলো, তুমি বলছিলে কি ফ্র্যাকচার, অস্টিওপোরোসিস, তাই তো? Yes, osteoporosis is a long-term effect of estrogen deficiency on women. On average, females have got a higher propensity to fractures beyond menopause. The reason behind is there is definite loss of bone mass after menopause. How much? Again, there is an MCQ question like this, it happens. That is, the women on average lose 1% bone mass per year after the age of menopause. So that by the age of 70 years, it has been computed and showed by statistical analysis that by the age of 70 years, women may lose up to 30% bone loss. Okay, 1% bone loss per year approximately, which comes down to about 30% bone loss per year by the age of 70 years. And unfortunately, some of them do have a fracture from a very trivial trauma, not a severe trauma, it's trivial trauma. So, and that's why the question of hormone replacement therapy has come up. Idea behind is whether you can stop this advancement of osteoporosis and thereby indirectly prevent fracture of the bones. Then the cardiovascular diseases. Now, cardiovascular diseases, they show different sorts of results regarding hormone replacement. We are coming to that later. And of course, the mood change, depression and dementia, that is also important. Now, urogenital atrophy and symptoms. Again, I am giving you statistics because MCQ question also occurs from these statistics. That is, in one study, the vaginal dryness was seen to be 4% in early menopause, 21% in late menopause, and 47%. That means almost half the women in 3 years post-menopause. So you can understand the magnitude of this problem. Now the question then will be the hormone replacement therapy. HRT, this term has come up, which means for a menopausal woman, you give certain hormones as a sort of, you can call it prophylaxis, or sometimes also for active treatment. Particularly senile and atrophic vaginitis, it is a treatment. And in case of osteoporosis prevention, it is the prophylactic one. The question then comes whether we should do or give HRT or not, yes or no. Actually, there was a study, WHI, Women's Health Initiative, a long study, multi-center, for a long period of time, and they have come to a conclusion that yes, estrogen replacement definitely can reduce osteoporosis, prevent prevention of fracture, etc. This is the positive side. The negative side is they have seen that using these drugs for a long time, there's a definite increase in thromboembolic diseases, and there is definite risk factor for cardiovascular diseases, and in some cases definite risk factors for breast carcinoma. So following all these findings, what happened, the opinion now is a little bit not so clear cut regarding replacement. Only thing is, there are two conditions where you can have hormone replacement therapy, definitely. Yes? Yes, so from the symptomatic point of view, severe hot flashes, sweats and headaches, that is severe menopausal symptoms, you are very much justified to use it. That is number one. Number two, if there is a premature menopause, there also, premature menopause, there is a lot of things to be said regarding the life of the woman concerned, or rather the quality of life of the woman concerned, and it definitely can give HRT. But then again, while giving this estrogen therapy, question comes whether you have got an intact uterus or not, because your treatment will be different. Without uterus and with uterus, the treatment is entirely different. Because if the uterus is not present, you are very happy and you are very free to use estrogen. Because the end organ is not there. It will not stimulate the endometrium. But if you have the uterus, then giving estrogen alone, there is a lot of chance of uterine hyperplasia, and even in the long term, maybe malignancy. Then it comes, in such cases, it is better to give estrogen plus progesterone. That means progesterone will antagonize the effect of estrogen on the endometrium, and hyperplasia, etc., will not occur. And not only that, you will have to review the woman from time to time. Because if you don't review from time to time, then sometimes you may come into a deep trouble. So every 6 months at least, you should re-evaluate, and you should take vaginal cytology for screening any malignancy, etc. And also endometrial thickness. If the endometrial thickness is 4 cm or less, it's alright. But if it is more than 4 cm, a bit of caution, because possibly endometrium is getting stimulated. So clear at this point whether HRT will give it or not. Main point then is, if there is severity of the hot flashes or menopausal symptoms, you can give it. Number two, in case of severe atrophic vaginitis, senile vaginitis, yes, you can do. Number three, definitely you should give in case of diagnosed premature ovarian failure or premature menopause. But clinically, another important, this is also, here you can have a MCQ question from that. Use of this combined OC pill for HRT, they have seen 3 significant disease pattern has come out. What are these 3? Number 1 is, it increases the incidence of CVA, cerebrovascular accident or stroke, whatever you say. Number 2, deep vein thrombosis, DHT, and number 3, gallbladder disease. So while you are giving estrogen therapy for a long-term basis, you should also take the at least have this profile of the liver enzymes, different or liver function test, whatever you say, to find out the base level activity of the liver and whether enzymes are already raised or not. If it is already raised, word of caution, should use it with a lot of precaution. Now let us come to the next, another important question that you should have prepared: contraindications to hormone therapy. Now sometimes in our branch, it is more important to know the contraindication rather than the indication, because contraindication is such a thing where if you give a drug where it is contraindicated, it's really dangerous, and you can have these days a lot of litigation problems in cases and all this. যেটা দেয়া যাবে না সেটা কিন্তু আগেই জানতে হবে, কোথায় দেয়া যাবে সেটা না কম জানলাম ঠিক আছে, but you must know একদম categorically that this is contraindicated in such conditions, so never be given. So what are those conditions? Uncontrolled hypertension, known or suspected endometrial or breast. And the third, that is very, very important, undiagnosed vaginal bleeding. Patient has come to you complaining of vaginal bleeding occurring for 3 months, 6 months, 1 year, whatever it is, and you then come to the proper history, clinically examine, and then the very next should be, you should go for some biopsy, isn't it? Take sample of the endometrium and vaginal smear and cytological study for malignancy and all these things, and you come up with all these things, you find out clearly there's a benign condition, no evidence of malignancy proven, you can give it. But malignancy cannot be ruled out, should never be given. So, undiagnosed vaginal bleeding, never ever go for this HRT therapy. Then, active liver and gallbladder, I have already said, because many of the liver enzymes are raised. Why these enzymes are raised? Actually, these estrogen and progesterone hormones, they produce some sort of hepatocytes to be sort of injured or destroyed like that. So whenever such things happen, the hepatic enzyme systems mostly are increased. So if you find in the liver function studies, this SGOT, SGPT, alkaline phosphatase, all these things, they are raised. Never ever venture to give it. And ischemic heart disease and cerebrovascular disease. So all these are conditions where you should never give, or it's a contraindication. Now, drugs commonly used for HRT, we have already said conjugated equine estrogen, that is Premarin, and the dosage is 0.3 to 0.625 milligram per day. You can also give micronized 17-beta estradiol, which is 0.5, 1 and 2 milligram per day, and estradiol valerate, already I have said, estradiol, that is 1 to 2 milligram per day. Regarding progesterone, the common progestogens used are medroxyprogesterone acetate, MPA, usually 2.5 milligram per day continuously, or you can give 10 milligram MPA per day for a period of 12 to 14 days. There are two ways of giving progesterone. You can give continuously, or you can give in the second half only, that is 10 to 12 days or 12 to 14 days of the month, this 10 milligram MPA per day. When given sequentially, there is a chance of vaginal bleeding occurring. Around 80% of cases there will be such bleeding. Now comes the question of ACRM. Somebody said about some, selective estrogen receptor modulator. What is it actually? No, You have come closer to the question. Your answer is partly correct. I'm not saying you're wrong, but a little bit more elaboration will make it clear. What is it? The estrogen receptor modulator means there are drugs which has got tissue specific action. In some cases, they behave as agonist to estrogen, and in some ways, they behave as antagonistic to estrogen. And this is tissue selective. That is called selective estrogen receptor modulator. And what is he has said is partly correct that it upregulates or downregulates the receptor status so that in some cases it acts like agonist and in some cases it acts like antagonistic. Okay. For example, one important is the raloxifene. Now, raloxifene is agonist on bone but antagonistic on uterus and breast. Agonist in case of bone, that means beneficial effects on the bones, but antagonistic against uterus and breast. Dose 60 milligram per day, and definitely because it is antagonistic to the endometrium, etc. So endometrial multiplication, hyperplasia, these all will be less, and the risk chances of carcinoma developing will also be much less. Standard dose is 60 milligram per day. Just a few lines regarding postmenopausal bleeding. By definition, postmenopausal bleeding is when bleeding occurs once the menstruation, menopause has been established for a period of 1 year or 12 months, then we call it postmenopausal bleeding. Now, regarding the causes, vulvovaginitis, vulvar carcinoma, vagina atrophic vaginitis, traumatic and vaginal carcinoma, and then cervix, of course, polyp, cervicitis and carcinoma cervix, uterus, endometrial atrophy, fallopian tube, only carcinoma can cause it, adnexal ovarian carcinoma, and particularly hormone producing tumor, that is granulosal tumor. And systemic causes should also be investigated, like bleeding disorder, use of anticoagulant drugs, and exogenous hormones, tibolone, estrogen, etc. Regarding this PMP, a thorough history is to be taken. Clinically, patient is examined, and then you make certain basic investigations to rule out basically any new development, that is neoplasm of the total genital tract. If there is any neoplasm of the genital tract, you treat accordingly. Otherwise, you reassure the patient. Okay.